Welcome to Chapter 4 Cognitive Disorders. Cognitive disorders are a group of mental health conditions that primarily involve disruptions in cognition, which refers to mental processes such as memory, reasoning, problem solving, perception, and judgment. These disorders can affect individuals' ability to think clearly, process information, and make decisions, which can lead to significant impairment in daily function. Cognitive disorders can be caused by a variety of factors, including age, brain injuries, infections, substance use. Key terms for you to understand this subject material, learning objectives, which you should know by the end of this lesson. So, overview. Introduction to our cognitive disorders. Cognition is the brain's ability to process, retain, and use information. Our key abilities include reasoning, judgment, perception, attention, comprehension, memory. Cognitive disorders impairs these cognitive functions and disrupts daily life. Um, it can lead to severe issues like forgetting family members, inability to perform tasks, and neglect hygiene. DSM-5 categories of neurocognitive disorders are delirium, and then we have mild neurocognitive disorders, which have modest impairment performance. They're not going to interfere with independent living, but they may require accommodation or assistance. And then we have major neurocognitive disorders, which have significant cognitive decline. The focus of your chapter really is going to highlight the care of clients with these cognitive disorders. So there'll be two nursing concepts at the end of this lecture. So our delirium. Delirium is a syndrome involving conscious and change in cognition. It develops quickly, matter of hours, and it fluctuates throughout the day. Clients are going to experience difficulty paying attention. They're going to be easily distracted and disoriented. They might have sensory disturbances like illusions. An electrical cord is going to look like a snake. Misinterpretation, maybe something noisy outside, like a door being slammed, is going to be a gunshot. They might have hallucinations where they're talking to somebody who's not there. We're also going to see some sleep-wake disturbances, changes in psychomotor activity, and emotional problems like anxiety, irritability, maybe some apathy or euphoria. Most affected group for this is going to be our older adults. About 14 to 24% of hospital admissions for general medical conditions end up with delirium. You might have heard of ICU delirium, and about 70 to 87% of ICU patients suffer from delirium. 80% of terminally ill patients, greater than 50% of hip fractures, 30% of open heart surgeries. So pretty high chance that when you get into your nursing career, if you're in the acute hospital, you're going to see a client with delirium. Our causes, common causes, multiple stressors. So if we have drug toxicity, withdrawal, metabolic disturbances with organ failure, trauma to the central nervous system, um, risk factors, older age, hearing impairment, reduced food fluid intake, medications, cognitive impairment. And then we do note that children may be susceptible, especially with febrile illness. So delirium is usually a result of an identifiable physiological, metabolic, some type of factor is causing it. And we need to figure out what that is and reverse it. So, physiological or metabolic, if we have hypoxemia, electrolyte disturbances, renal or hepatic failure, hypo or hyperglycemia, dehydration, sleep deprivation, some other vitamin imbalances like deficiencies in thiamine, vitamin B, vitamin C, niacin, protein, cardiovascular shock, brain tumors, head injuries. The list goes on. We can also have infections causing it. So we can have systemic, like our urosepsis or pneumonia, or we can just have cerebral, where it's like meningitis, encephalitis, HIV, syphilis. We can have drug-related causes like intoxications. Um, it could be intoxication due to lithium, alcohol, sedatives, hypnotics. We can have withdrawal from alcohol, sedatives, and hypnotics. And then we can have reactions to our medications, like reactions to anesthesia, prescribed medications, or illicit drugs. So lots and lots of causes of delirium. What's our treatment? The treatment is to identify and treat the underlying medical condition causing the delirium. Usually resolves once that underlying cause is addressed. So depending on what that underlying condition is, would be how long it lasts. Um, and then we have our risk for future episodes, right? Individuals who have experienced delirium are at a higher risk for future episodes of it. Psychopharmacological, right? Our big thing is we want to keep them quiet. There's really no specific medication to address this. However, if your client is really agitated or psychotic, we might want to use the antipsychotic of Haldol. Haldol helps with that agitation, that psychosis, and it helps to facilitate sleep. It can be given orally, IV, or IM. We might want to sedate the patient to prevent injury. We do not want to use benzos. Usually, benzos will worsen the delirium, especially in our older adults. The only exception to this would be if your client is having delirium because they're withdrawing from alcohol. Then we're going to want to treat it with benzos. Other medical treatments, we want to use supportive measures, make sure that they have adequate nutrition, adequate fluid intake. We might need to start them on TPN. We might have to use physical restraints, especially if the client is agitated and they're at risk of dislodging medical equipment. But remember, restraints are, minimally used. And, if we can put a one-on-one with them, it would be better. So now our nursing process, right? This is that concept map. What's our client with delirium assessment going to look like? So when we're doing the assessment, we want information, right? Information about what prescribed medications are they on? Are they on any over-the-counter medication? Are they on any illicit drugs? We want to make sure that the combination of medications might not be causing the delirium. Their general appearance and motor, they're going to be a little restless. They might have some hyperactivity. They might be picking at things, attempting to get out of bed, really uncoordinated. They might be sluggish. They might be lethargic. So that picking is sometimes very rapid, or sometimes it's really, really like slow. Speech changes. Speech may become completely incoherent. It could be rambling. It could be pressured. Sometimes the clients will be noted to just be screaming. Their mood and affect, usually it's going to be rapid, unpredictable shifts. We might have some emotional responses of anxiety, fear, irritability, angry, apathy. When fearful, clients can become combative. They might perceive that you as a threat. Their thought processing content. Cognitive changes, they might have difficulty with attention, really making it harder to process and accurately assess them. Their speech may be illogical and fragmented, making disorganized thoughts. And they could be having delusions and hallucinations, so we need to be mindful of that. When we're looking at our sensorium and our intellectual, again, hallucination, seeing things that aren't there, illusion, misinterpretation of actual stimuli. Um, one that I'm so used to seeing is they believe that the IV pole is somebody behind them and they're talking to the IV pole. And when you move the IV pole, they'll like follow it and continue to talk to it. Um, Impaired attention and memory, difficulty focusing or following instruction, disoriented to time and place, but they're usually oriented to themselves, and altered level of conscious. Really, we have fluctuations in their level of consciousness throughout the day. For judgment and insight, we're going to have impaired judgment. They might not recognize that pulling out the IV lines is really harmful. With their insight, mild delirium may allow clients to recognize confusion, but severe delirium is going to have no insight at all. Roles in relationships, they're not going to be able to fulfill their roles during delirium, but typically they'll regain function once the condition resolves. For self-concept, there's no direct impact. Delirium doesn't directly affect self-concept, but it can lead to helplessness, guilt, and shame, especially when it's compounded with substance use. Physiological and self-care deficits. So our sleep-wake cycles are disturbed. They might have insomnia, they might have daytime sleepiness, they might have reversal of their sleeping patterns, so they're awake during the night and they're asleep during the day. And they may have failure to perceive body clues. So they may ignore being hungry, thirsty, might ignore the urge to urinate or defecate. So, with all that, when we're talking about our diagnoses and our outcomes, your priority, right, as always with all mental health is, safety, right? So, these guys are a huge risk for injury, concerns for their acute confusion, some additionals, hallucination, and other sensory disturbances, disorganized or disrupted thought process, inadequate sleep or rest, dehydration, inadequate food or fluid intake. Your outcomes are going to be based on what diagnosis or concept you used, right? So if you chose risk for injury, your overarching outcome should be that your client doesn't have injury. If we're doing confusion, you're going to want to make sure that, they can demonstrate increased orientation and reality. If we're looking at sleep, rest balance, adequate balance of activity and rest, um, and so on. So, what is our actual implementation and evaluation? So, actions when we're talking about promoting safety, safety is always the prioritization, right? And if we're using something like Haldol that's going to make them sleepy, they're really at an increased risk for falls. We want to make sure that they have maybe a one-on-one with them, or that, you put a bed alarm. So if they get out of bed, we at least know. We want to make sure that we're doing our hourly rounding, getting them to the bathroom. We want to respond rapidly if that client calls out to us. And then remember, physical restraints is really your last resort. Even if you can facilitate a family member sitting with them, that's better than restraining them. If we're talking about managing the client's confusion, you want to make sure that you're speaking to them in a calm approach. We want to use realistic reassurance. We want to use um, make sure that we're facing our clients when we talk to them. Use simple communication, short, simple sentences. Provide orientation clues like their name, the time of day it is. Frequent reality reorientation. Use of touch is very careful here. We want to make sure that we're not frightening them. Try to reduce sensory overload, so minimize noises and distractions. Keep the environment calm, and then correct misconceptions, right? If the client says, "Oh my God, did you hear that gunshot?" No, that wasn't a gunshot. That was just a door being slammed closed. Promoting health and proper nutrition, if that's what you're going to implement, right? We want to monitor for sleep and nutrition. We want to encourage adequate intake. We might have to have somebody sit with them while they're eating to help them finish their meal. Encourage regular bathroom assistance, and then promote sleep. So we might need to discourage daytime naps and encourage some physical activity. And then, of course, evaluation would be depending on what you implemented and how you're going to evaluate it. Delirium and community-based care. So post-delirium gives some cognitive changes. Even after delirium resolves, some clients may continue to experience cognitive impairments and some confusion. If delirium is accompanied by dementia, a thorough medical evaluation should be conducted to confirm dementia and begin the appropriate treatment. Referrals for ongoing care. They might need home health or a visiting nurse. We might need to do rehabilitation programs so that they can get some strength back up. We might put them in community programs like adult daycare or residential care, which can help provide continued support. And you want to make sure that you're getting support for the caregivers as well. We might point them in the direction of support groups. So this slide is just to kind of compare delirium and dementia. And we're going to be going over dementia next. But, right, dementia is that slow, progressive, kind of that insidious onset. And then delirium is that rapid one. And it's really important to know the difference between the two of them. You can have somebody who has dementia that gets delirium, right? Because if your baseline is dementia and then you have urosepsis, you might have delirium on top of it. So, delirium is going to have the mood swings, the illusion, the lack of insight, the impaired memory, impaired level of consciousness, and again, rapid onset of symptoms, whereas dementia really should have no changes in the level of consciousness. We could have impairments in our short-term and long-term memory. They're going to have difficulty thinking, maybe some anxiousness and some liability, but it's really a slow progression of the symptoms, whereas delirium's like overnight. So, our dementia overview. All right, the definition. Dementia is a disease marked by progressive cognitive impairment without changes in consciousness. It involves multiple cognitive deficits with memory impairment as the initial symptoms, followed by other cognitive disturbances. When we talk about cognitive disturbances, we can have aphasia, which is the deterioration of language function, apraxia, which is the impaired ability to perform motor functions despite intact motor abilities. Agnosia, inability to recognize or name objects despite intact sensory abilities. Executive functioning disturbances, which are impaired ability to plan, sequence, monitor, or stop complex behaviors. DSM-5 classifies this as mild or major. Mild is going to be that mild cognitive decline, modest impairment in performance, not really interfering with independent living, but they may require accommodations or assistance. Major is significant cognitive decline. This is going to interfere with activities of daily living. Again, your dementia versus delirium. Dementia is distinguished from delirium as its symptoms are persistent even after the delirium has cleared. Dementia is long-standing. Delirium is that quick onset of symptoms, but as soon as we fix the underlying cause, it's better. Your progression of symptoms with dementia, early stages is going to be memory impairment, forgetting where objects are placed, having difficulty learning new information. As we get into our later stages, we have remote memory loss. So forgetting family members' names, what their lifelong occupation was, even what their name is. So progression, When no underlying treatable cause is found, dementia usually progresses in stages. So we have our mild stage, where we're going to have symptoms of forgetfulness, difficulty finding words, misplacing objects, and they might even have anxiety about memory loss. The social impact, they're going to have decreased enjoyment in social and occupational settings, and avoidance of activities. And for their independence, most individuals remain in the community during the stage. When we hit the moderate stage, symptoms are increased confusion, progressive memory loss, inability to perform complex tasks, disorientation in time, difficulty remembering personal information like their address or phone number, social impairment, loss of ability to live independently. They may require assistance. Their living situation, they can remain in the community if they have caregivers to support them sufficiently. Some at this point need to be moved into supervised living situations. In the severe stage, our symptoms are going to be personality and emotional changes, wandering behavior, memory loss, names of their spouse and children, inability to perform activities of daily living. At this point, they usually need to be in some type of supportive care. Our causes, again, we don't know. We know that there's some genetic factors. Some dementias have links like Huntington's disease and Alzheimer's disease. Some we could note back to infections like HIV and Creutzfeldt-Jakob disease. Those can lead to dementia. We could have metabolic activity, so decreased metabolic activity in the brain, but it's really unclear whether it's the cause or the result of the dementia. And then sometimes we have postmortem diagnoses. So our types of dementia, Alzheimer's. So most frequently seen, onset's gradual, symptoms are progressive cognitive decline. We're going to have speech loss, motor dysfunction, personality changes, brain changes, so atrophy of cerebral neurons. They have plaques and enlarged ventricles. Risk factor or age and genetics. Duration, usually after symptoms, it's 8 to 10 years until death. Lewy body dementia, onset is gradual. These guys have cognitive impairment, neuropsychiatric issues, delusions, visual hallucinations, and motor symptoms. Genetic component, less common, but some genetic genes have been identified. Vascular dementia, this has a more abrupt onset of symptoms, but it plateaus out. So we'll have a rapid decline and then we'll kind of freeze at that area for a long period of time. Then we might have another rapid decline. Symptoms are really similar to Alzheimer's, but the big difference is the rapid change in function. And what we see in these scans are multiple vascular lesions due to decreased blood flow. When we talk about frontal temporal lobar degeneration, this onset's usually between 50 and 60 years old. We're going to see personality changes, loss of social skills, language abnormalities. Progress is really rapid. Death is at about 2 to 5 years, and there's a strong genetic link with that. Prion disease, which is Creutzfeldt-Jacob's disease. Rapid progress, about months. We have altered vision, coordination loss. It's due to the infectious prion proteins. Right, cows, this is mad cow's disease. HIV-related dementia varies related to the HIV infection. Toxoplasmosis for cytomegalovirus. Our symptoms are cognitive deficits, memory losses, muscle atrophy. If you ever have a client who has a history of sexual promiscuity without protection, or if they're an IV drug user, and we're having cognitive changes in memory issues, they should really be assessed for HIV. Parkinson's, gradual onset. We're going to see the symptoms of the tremor, the rigidity, the bradykinesia, postural instability. They're going to have a cognitive decline in about 25% of 75% of cases, and issues with memory and executive function impairment. Huntington's disease, late 30s, early 40s, due to Chiari malformation or Chiariform movements, sorry. Personality changes, memory losses, and cognitive decline. There is a genetic component to that one. And then traumatic brain injuries. So immediate or delayed onset really depends on the severity of the injury. Symptoms can be cognitive and behavioral disturbances. Progression, stable with a single injury, but progressive with repeated injuries, which is why when we have somebody who has a traumatic brain injury, we really don't want them collecting concussions. So our treatment with dementia, treatment and prognosis for dementia. If they have an underlying cause, we want to treat the underlying cause. So when we look at vascular dementia, we really need to control their hypertension, their diabetes, or any other vascular issues. We want to improve that cerebral blood flow. If there is no underlying cause, then that's not an option. For our prognosis, we have progressive deterioration in physical and mental abilities, typically until death for all of these. The later the stages they become, the more cognitive and functional impairments we have, which makes them really rely on their caregivers. For therapies, there's no cure for degenerative dementias. Treatments really aim to manage the symptoms and slow the progress. So we can do the cholinesterase inhibitors like Aricept, which modestly slow the dementia progress, but they really do not alter the disease course. We can use NMDA receptor agonists like Namenda, for moderate to severe Alzheimer's slowing. And then we do a lot of symptom treatment. So if our client is having some depression, we're going to use our SSRIs. Those are your most preferred for our elderly clients. And we just always make sure that, it's a low dose. So you may see a dose that's like sub-therapeutic to the average adult, but for these guys, it's therapeutic. If we're having a lot of delusions, hallucinations, paranoia, agitation, we're going to be looking at our antipsychotics. If we're having some mood, emotional liability, we might use mood stabilizers. Benzodiazepines used very, very cautiously with these guys. As I said, with our delirium patients, we really do not want to use benzos. We want to use that Haldol because benzos can worsen the delirium. And with these guys, it can also worsen their cognitive impairments. So our nursing process with dementia, right? We're going to start out with our assessment. So history, the client might not be able to provide an accurate history due to their memory impairment. So you're really going to be laying on the family. How long have we been declining? When we're looking at our general appearance and our motor behaviors, we're going to have the aphasia, difficulty speaking, apraxia, difficulty with tasks. And we might have uninhibited behaviors like inappropriate jokes, hygiene, neglect, and things like that. Our mood and affect, we can have labile moods, emotional outbursts, anxiety, aggression, withdrawal, and apathy. Our thought process and context, impaired abstract thinking, loss of ability to solve problems, plan tasks, might see some delusions. With our sensorium and intellectual process, we're going to have memory deficits, confusion. They might make up answers. They might have a loss of recognition. They might have some hallucinations. With our judgment and insight, poor judgment, unrealistic self-appraisal, limited insights, all due to their deficits. Self-concepts, a lot of times we're going to see sadness, frustration, and loss of self-awareness, or roles in relationships. It's going to be difficulty maintaining work, um, stress in the family roles, relationships, and overall, they're going to become very dependent on their caregivers. For physiological and self care, a lot of times we have disturbances in sleep, incontinence, hygiene deficits, and they're going to need increased care to complete activities of daily living. So, your diagnosis and plannings, right? We want to make sure that they're free from injury, right? Safety, safety, safety. You know, we're going to need to help with that sleep, with their hydration. We might do some memory stuff, some impaired communication, inability to fulfill roles. And then, of course, our outcomes are going to be based on whatever diagnosis. So, if we're looking at risk for injury, we're going to be injury free. So, what actions are you going to do? What's your implementation? If we're talking about safety, right, we want to make sure that we are offering them the most restricted living possible. So unrestricted living, the safest that it can be. So they might need supervision of cooking, supervision of bathing, help with self-care activities. We want to identify environmental triggers so that we can help them avoid getting hurt. We want to make sure that if we're allowing them to do stuff, that we're providing single step instructions to keep them safe. We want to make sure that we're promoting adequate sleep, proper nutrition, and hygiene. We want to make sure that we have a structured environment. Um, these guys will thrive better without change. So we really want to make sure that the family offers them a regular routine and habits rather than trying to change things up and impose new ones. We want to make sure that we offer emotional support. We want to be kind. We want to be respectful, calm, pay attention to the client's needs. Again, caution with supportive touch. And we want to promote interactions and involvement by planning activities geared towards their interests. We can do things like reminiscent therapy, where we maybe go through like a photo album and they can tell us, reminisce about those past experiences. If we have a client who's, really giving a lot of attention and energy towards maybe wanting their family to come and they're crying about their family, we want to distract them. We want to shift that attention, that energy to a more neutral topic. Um, and then our dementia and community-based care. So, nursing home care, about 50% of nursing home residents have Alzheimer's. I guess for every nursing home residents, about 2 to 3 others are cared for at homes with families. So there's a lot of them in facilities and a lot of them out of facilities. We have adult daycare centers, which help offer supervision, meals, and support to help those families. Be aware of respite care, which can help families who are keeping their loved one in home, providing them with a break so that they can run errands and still have personal time. We might use referral services for home physicians, nurses, and other public health departments, social services, and hospitalizations. For our healthcare promotion, um, let's see, elevated plasma homocysteine levels have been noted for an increased risk of dementia. So, folate, vitamin B12, and betaine can reduce homocysteine levels. There's ongoing trials about that. Brain stimulating activities like crosswords can help to reduce developing Alzheimer's disease. Physical activities and social networks, so our leisure time um, with physical activity is better. Maintaining social networks is better. And then healthy lifestyle, healthy eating, minimizing health risks like hypertension and diabetes. All of those things can help promote health and reduce dementia. Next thing we're going to talk about is our caregiver role strain. So, we already know that there's a big population of people with dementia, or one of the subsets of it. About 34% of caregivers for those with dementia are usually over the age of 65 themselves. Two-thirds of those are women, and with one-third being adult daughters. Two-thirds of caregivers live with a person with dementia in the community. Reasons for family caregiving. It's a really high cost and dissatisfaction with those institutional places like the assisted living centers. Caregivers also report feeling a sense of duty and loyalty, and they need to reciprocate for past care that their parent provided to them. Caregiver responsibilities. Caregivers really need to understand that dementia is progressive, and we need to help them with managing family dynamics. Um, and they're going to have loss and grief, and all of that's common as the loved one's health declines. So they face a lot of challenges, a lot of emotional and physical exhaustion. Remember, this is a 24/7 caregiver role. So that role strain manifests through fatigue, social isolation, neglect of personal needs, and sometimes develops into substance use disorder. So things that we're going to hear from the family member is that they are constantly fatigued, that they are feeling withdrawn. They might not say that they're having burnout, but they might start to neglect that loved one with dementia. So we need to offer support with them. It's really essential to provide them with education, and explain to them the different services that we have available to them, and to help them seek assistance if they need to. Um, Caregivers really need to maintain social connections, hobbies, and leisure activities to prevent burnout. No different than what we say for nurses, right? Like, you need to have that balance of self-care, good sleep, good diet, exercise, all that to keep you from getting burnout. Well, if you were 24/7 caring for somebody, we have that increased risk. So we just need to be mindful of that. And then, as always, I'm going to finish up with self-awareness issues. So challenges for nurses and caregivers. Caring for clients with dementia can be exhausting and emotionally draining. Teaching clients with dementia is very difficult because they often do not retain explanations or instructions, which requires constant repetition. Nurses must avoid frustration and maintain patience, which can be challenging, especially when progress seems minimal. Frustration and emotional toll. Nurses can start to feel disheartened if they perceive that their efforts are ineffective, particularly when clients do not respond or remember instructions. There can be a sense of loss when the client continues to decline or loses the ability to perform tasks that they were once able to. We need to remember that the progression of dementia also leads to long, slow decline, which can result in prolonged emotional and professional stress, for you, the nurse, as well as the family member. So, coping with emotional strain, it's important for nurses to acknowledge and process their feelings of frustration, sadness, and grief about the inevitable decline in their clients' outcomes. Discuss their feelings with colleagues or other healthcare professionals, or even a counselor themselves. This will help to avoid burnout and reduce your emotional exhaustion. You should also focus on remaining positive and supportive. Make sure that you're doing your own self-care, as I said in the last slide. Make sure that you're meeting your own emotional needs, eating well, sleeping well, um, and then, of course, maintain your own support network and have open communications. And that is the end of this lecture.